we'll look through all your comments in the chat, so please just send those our way. This is our last talk for this academic year, but we look forward to seeing you in the fall for future talks. Today, I'll be introducing our presenters and our respondents. So we have Dr. Mika Hamer, who will be presenting today. She is a postdoctoral research fellow with the University of Colorado Center for Bioethics and Humanities. She completed her PhD in health services research at the University of Colorado in 2022. This fall, she will be joining the faculty at University of Maryland School of Public Health. We will miss you. In her research, Dr. Hamer uses quantitative and qualitative data and research methods to explore questions about the effects of healthcare policy on healthcare access and utilization, especially among older adults and individuals with life-limiting conditions. We're also pleased today to have Dr. Art Caplan with us as a respondent to Mika's talk. He is currently the Drs. William F. and Virginia Conley Mitty Professor and founding head of the Division of the Medical Ethics at NYU School of Medicine in New York. Prior to coming to NYU, Dr. Caplan was the Sidney Caplan Professor of Bioethics at the University of Pennsylvania, Perelman School of Medicine in Philadelphia, where he created the Center for Bioethics in the Department of Medical Ethics. Dr. Caplan is the author or editor of 35 books and over 860 papers in peer-reviewed journals. Thank you for being here today. Mika, we can have you take it away.
Fantastic. All right. If I could just get a thumbs up from anybody on the panel to make sure that my slides are showing. Yes, great. Okay, well, thank you so much, Gianna, for that warm introduction. And thank you, Dr. Caplan, for being here today to respond to this paper. I'm really thrilled to share our work on physicians' conscience-based barriers to medical aid in dying. This is some work that I completed during my postdoctoral fellowship here at the Center for Bioethics with an esteemed group of colleagues. There we go. So to lay some kind of a track for where we're headed today, the objectives of this paper and this research were first to measure physicians' religious and or ethical barriers to participating in MAiD or medical aid in dying services, and then subsequently to understand how religious and or ethical barriers relate to physicians' intentions and actual behavior when it comes to medical aid in dying. Before I get too far into this, I just want to acknowledge the fantastic team that I had the opportunity to work with, colleagues from across the University of Colorado campus, folks from the Center for Survey Research at UMass Boston, and another colleague from the Weill Cornell Medical College in New York. A little more on the admin side here. We're grateful for funding. This work was supported in part by the Greenwald Foundation's Making a Difference program. No one on our team, myself included, has any conflicts of interest to disclose. Importantly, we take no public position on the acceptability of MAiD from a legal, ethical, or social perspective, and nothing that I say or present today is intended to cause, promote, or assist in medical aid in dying in any way. One more sort of ground setting piece that I want to cover before I dive into things is that medical aid in dying goes by a lot of different terms. The terminology around this practice is controversial and value-laden. For instance, some strongly prefer physician-assisted suicide or physician-assisted death. Sometimes the choice of terminology conveys a particular position with regard to the practice of MAiD. But because this is an empirical study that was based in Colorado, medical aid in dying is the term that's used in the Colorado state law. That's the term that I'll use throughout my presentation today for consistency and accuracy with the Colorado law. So just to start by getting us all on the same page, medical aid in dying, or MAiD, as I will refer to it throughout this presentation, is a process through which a physician provides a competent, terminally ill patient with a prescription for a legal dose of medication that, when taken by that patient, will end their life. There's some variability in eligibility criteria, but most importantly, it's available to adults who are age 18 years and older. They must be a resident of the state where the procedure is taking place, with the exception of Vermont and Oregon. where they recently changed the residency requirements. Patients must have a prognosis of fewer than 6 months as determined independently by 2 different physicians. They must have a capacity to make an informed decision about their care and end-of-life preferences, and they must have the ability to self-administer the medication. Dr. Jonathan Treem, who's a colleague here at the University of Colorado, recently described that medical aid in dying is intended to be a thoroughly thought out and planned decision, not a spontaneous one. And again, because the process varies a little bit based on the state or jurisdiction that we're talking about, I've laid out here sort of the general process of how this goes. It involves a lot of different steps, but in Colorado, at least, patients must request verbally medical aid in dying at 2 separate instances, separated by at least 15 days. That waiting period is being reduced through a recent amendment to the Colorado state law. But nonetheless, there is a waiting period between these 2 requests. At that point, the consulting physician steps in to verify that the patient qualifies under the requirements of the law. A licensed mental health professional may also be invoked at this point in the process. Next, an attending physician will fulfill their requirements, which also requires verifying that the patient qualifies under the law, as well as working through things like the patient's written statement that must be witnessed by someone else, verifying proof of residency, having conversations about risk, burden, and benefits with the patient, and also obtaining informed consent. After all of that has been completed, the attending physician prescribes the medication, at which point a patient may or may not actually fill the prescription. If a patient is to take the medication, they have to self-administer it, but also once they've received their prescription, they're not required to take it. Subsequent to that, the attending physician fulfills their documentation requirements, both around prescribing and also death certificate signatures if needed or relevant. Currently, about 25% of the US population lives in one of the 11 states and jurisdictions where MAiD is legal. The earliest state to legalize MAiD was Oregon in 1994, and the most recent state was New Mexico in 2021. Colorado's right in the middle, with MAiD becoming legal in 2017. And in the most recent legislative session, an amendment has added advanced practice providers as evaluators and prescribers of MAiD, and has also reduced the waiting period from 15 days down to 7. Every legislative session, MAiD pops up in lots of states. It's in consideration in many, many more states, and we see that happening all the time. So MAiD gets a lot of attention in the news. You may wonder, who is actually using MAiD? This figure, which reports data from the Colorado Department of Public Health and Environment, shows the trends in patients prescribed and dispensed aid in dying medications from 2017 to 2023. So again, 2017 is when it first became available in Colorado. So you'll see there's an upward slope with utilization of MAiD increasing over time. With the blue line on the top of this figure, that's the number of patients year over year who were prescribed aid in dying medication. You will see that the orange line, the patients to whom aid in dying medication was dispensed, is lower. So not everybody who has a prescription written actually fills that prescription. And then the gray line with the triangles indicates the patients prescribed aid in dying medication who have died. And it may be that those individuals die by taking their aid in dying medication, or it may be that they die of other causes in the interim before actually engaging in MAiD. To put this into context, so we've got, let's see, there are about 8,000 cancer deaths in Colorado each year. So that's cancer alone, cancer of all types. Between 2017 and 2023, there were a total of approximately 1,500 MAiD prescriptions written in Colorado, and medication was dispensed, again, over those, the entire 5-year period from 2017 to 2023. Sorry, 6-year period. Medications were dispensed to a little over 1,100 unique individuals. So again, although this gets a lot of attention, The scale of utilization in Colorado, at least, is quite small relative to the number of people who may qualify based on their clinical conditions. Which is a great segue into answering the question of who was prescribed MAiD in Colorado between 2017 and 2023. About 2/3 of individuals who were prescribed MAiD medications had malignant neoplasms. This is cancers of all types. The next largest group of folks are those with progressive neurological or neurodegenerative disorders. We then see a smaller piece of the pie for folks with cardiovascular disease or lung diseases, and then an even smaller piece of the pie with other things like chronic kidney disease, chronic liver disease, among many others. So shifting a little bit, this comes into the realm of conscientious objection, which specifically is a physician's exercise of their rights to refuse to provide medical services that conflict with their deeply held ethical or religious beliefs. Conscientious objection and the right to do so is consistently upheld by laws, hospitals and health systems, professional organizations, policymakers. Conscientious objection is observed in the provision, not necessarily frequently, but observed in the provision of abortion care, medical contraception, gender affirming care, participation in executions, and medical aid in dying, among many other services. We also see objection happening institutional level. So for example, several years ago, there was considerable attention to a Colorado doctor who was fired after she sued her institution, which was a religiously affiliated institution, because she wanted to provide a patient with aid in dying, and the institution argued that conflicted with their religious beliefs, whereas she argued that it conflicted with her duty as a physician to not abandon her patient. So this is something we see objection happening both at sort of the local and physician individual level, also at the institutional level. Nonetheless, there's relatively little empirical data to inform policy and practice of MAiD. This stems from a variety of reasons, and in part is by design. So state laws forbid releasing identities of MAiD patients or providers. This is to preserve their privacy and in some cases their safety. Pharmacies are barred from identifying MAiD prescribers or the folks who fill those prescriptions. Importantly, neither MAiD prescriptions nor MAiD visits are covered by insurance, and so these aren't directly observable in things like billing and claims data that we might get from an insurance company that we often use to look at utilization in the healthcare space. By statute, death certificates don't include MAiD information. Medical examiners are instructed to indicate the underlying cause of death rather than MAiD as the cause of death on death certificates. It's also been reported that some doctors fear being identified as a MAiD provider, and the potential, financial, social, legal implications that may come with that. But finally, there's advocacy interests around both sides of the argument, whether it's in favor or against MAiD, but interests in the narrative and the data that can be used to drive policy changes related to MAiD. One concrete example that I will give is around the potential for discrimination when it comes to MAiD. So whereas Death with Dignity, which is a pro-MAiD group, and you can perhaps tell based on their choice of language, even for their group name, they talk about how the laws and policies around MAiD and the eligibility criteria make it such that people would be unlikely to be discriminated against on the basis of disability status. By contrast, Not Dead Yet, the Resistance, which is an anti-MAiD group, is very concerned about the slippery slope and the potential for coercion and other forms of discrimination for people with disabilities. So very similar language and even data that gets used on both sides of the argument. And so to sort of put a finer point on this, existing data on physician barriers to MAiD come from qualitative studies, which may have small sample sizes, or from surveys that use hypothetical scenarios, soliciting physicians' opinions rather than data on their actual behavior. The vast majority of physicians in states and jurisdictions in the US do not have legal MAiD, and therefore often surveys are asking things like, if you were approached by a patient about this, what would you do? Surveys are often conducted with a general population of physicians, many of whom may not encounter requests or questions about MAiD in their general practice either. We also know that physicians may refuse to participate in MAiD for reasons other than conscientious objection. Physicians cannot be legally compelled to provide MAiD, whether or not they exercise their right to conscientious objection. And thus, the topic of MAiD provides fertile ground to empirically explore the frequency of ethical and religious beliefs as barriers to physician participation. So to sum all of that up, the objective of the present study that I'll spend the remainder of the time presenting was to explore the nature and extent of the association between physicians' self-reported religious or ethical barriers and their intentions and behaviors with respect to MAiD in Colorado. The data that we used came from a cross-sectional anonymous survey of Colorado-based physicians who provided care to patients who were likely to qualify for MAiD based on their clinical conditions and under Colorado law. I'll say more about that in just a moment. Physician willingness to provide MAiD and their actual prior participation in MAiD, since it was legalized in Colorado in 2017, was measured. The survey itself took fewer than 10 minutes to complete. It was fully anonymous, which limited our ability to follow up with people, but we captured very little, limited demographics and virtually no physician identifiers. It came with an upfront $50 cash incentive, and the survey was fielded in 3 waves in 2022 by the Center for Survey Research at the University of Massachusetts in Boston. The construction of the sample began from anonymized aggregated information on patients known to have received a MAiD prescription reported each year by CDPHE. That's the Colorado Department of Public Health and Environment. So they report annually on the clinical conditions among the people who have received a MAiD prescription. So that was that pie chart that I showed several slides back. From that list of conditions, we turn to the Colorado All-Payer Claims Database, which is an aggregate database of virtually all insurance claims across Colorado. Within that All-Payer Claims database, we identified patients with the conditions that would most likely qualify them for MAiD services. So this was in no way definitive, but simply saying who are the patients based on who we know to have already received a MAiD prescription, who might be likely to be looking for care related to MAiD. From there, we selected the clinicians or the physicians according to their specialty, their number of patients with potentially MAiD qualifying clinical conditions, and their practice setting to arrive at a final sample of 583 physicians. In short, we were identifying physicians in Colorado who were caring for the largest number of patients who had similar clinical characteristics as those patients who were known to have received a MAiD prescription in the past. Those are the folks who were sampled. And for the identification of physicians with conscience-based barriers, we were looking for folks who said that, in general, how much of a barrier is each of the following for you to be involved in a MAiD case, who reported that either or both professional ethics and religious concerns, were a large barrier for their involvement in a MAiD case. And then from there, we assessed whether physicians with these conscience-based barriers acted in accordance with those beliefs more often than those who did not report those large barriers. We had 2 sets of outcomes that we were interested in. The first was intention outcomes. We used the survey question in general. If you were asked today, would you be willing to discuss MAiD with a patient, refer an eligible patient to another physician for MAiD, serve as the MAiD consulting physician for an eligible patient, serve as the MAiD attending for an eligible patient, and be present when a patient took the MAiD drugs. So this is really moving from a more ancillary participation with discussions and referrals to much more active participation with the attending physician being the physician who oversees the entire process and who writes the MAiD prescription. Our second set of outcomes were self-reported actual participation in the past. At the time, it was 4 years. So since 2017, when MAiD became legal in Colorado, have you discussed MAiD with at least one patient? When physicians responded yes to this, they answered the second set of questions. Since 2017, when MAiD became illegal in Colorado, have you referred a patient to another physician for MAiD? Have you served as the MAiD consulting physician on a MAiD case? And have you served as the MAiD attending physician on a MAiD case? So once again, we're really moving from the more ancillary aspects of the MAiD process to the much more active. Our statistical or analytical approach, we used multivariate adjusted logistic regression models to evaluate association between the presence of one or more of these conscience-based barriers and each of the outcomes, which we modeled separately. We applied survey weights to account for a 3-wave sampling strategy, and we report the results as marginal effects, which you can consider to be predicted probabilities, which just facilitates interpretation from the logistic. So I'll share in some very small fonts some sample characteristics, but in particular, what I'd like to draw your attention to was this finding that physicians who had spent a longer duration in practice were much more likely than those who had spent fewer years in practice to report having conscience-based barriers, either religious or ethical in nature. So this is the overall distribution of ethical and/or religious concerns being a large barrier to a physician's involvement in a MAiD case. Overall, we found that 26% of our 300 respondents reported having conscience-based barriers. There was significant overlap between having ethical barriers and religious barriers, represented by that medium gray on the right-hand side. So about a third of our barrier holders had ethics barriers only. Another 2/3 had both ethical and religious barriers, and then a slim percentage had religious barriers only. So in all, this was about 80, not about, it actually was 87 people who reported conscience-based barriers of any type. We also found that ethical and religious concerns were highly correlated with one another, as indicated by the overlap here, but they weren't highly correlated with other types of barriers. For instance, concerns about the amount of time it might take or the emotional toll to engage in a MAiD case. So that suggests to us that these are people who really do have these barriers, and they're not simply people who see barriers in all aspects of MAiD. So getting into the results, in my opinion, the more interesting part of this figure displays the physicians who were definitely not willing to participate in MAiD activities according to their conscience-based barrier status. So the gold bars, they're kind of gold, beige, CU gold, are the folks who have conscience-based barriers to medical aid in dying, and the black bars are folks who do not have conscience-based barriers to MAiD. So what you can see as we move from left to right, again, from the more ancillary activities to the more active components, that the unwillingness to participate increases as we move towards a more active role. There's also a larger absolute difference in the more active components of MAiD between folks who do and do not report having conscience-based barriers, but it is statistically significantly different across the board. So to interpret this on the discussion of MAiD, almost 13% of physicians with conscience-based barriers said that they would definitely not be willing to discuss MAiD with a patient, whereas only 2.3% of physicians who did not report conscience-based barriers said they would definitely not be willing to discuss MAiD. That number increases greatly. Looking at serving as a MAiD attending, for instance, we see 81% of physicians with these barriers reporting that they would be definitely not willing to participate in serving as a MAiD attending, whereas closer to 30% of folks with no conscience-based barriers reported the same. Looking at actual physician behavior, we see some really interesting patterns. So among folks with conscience-based barriers, we see that they discussed MAiD at rates that are virtually no different, and certainly not statistically significantly different from folks who did not have conscience-based barriers. Around 50% of respondents in both groups had discussed MAiD with at least one patient since 2017. As for those 50% who said they did discuss, we saw a relatively similar proportion who had referred a patient to another provider for MAiD services. So it's a little lower on the side of physicians reporting conscience-based barriers, but not statistically significantly different. Where we see the differences show up is in the more active components. So whether it's serving as a MAiD consultant or a MAiD attending. A very small but not zero number of folks with conscience-based barriers did report serving as a MAiD consultant since 2017. This was only 5%, which really only represents a handful of our respondents. But nonetheless, that's compared to about a third of folks who did not report having conscience-based barriers. And then we see none of our conscience-based barrier holders serving as a MAiD attending, with about 22% of folks with no conscience-based barriers having served as a MAiD attending since 2017. As with any research, there are always limitations to note. And although we know that religious and ethical concerns are common sentiments that might underpin conscientious objection, they undoubtedly constitute the types of deeply held beliefs that would be necessary components of conscientious objection. We can't be certain that these particular physicians acted in accordance with these beliefs and that they exercised their right to conscientiously object. By design, we had limited demographic information to further characterize physicians with conscience-based barriers to MAiD due to the anonymous nature of the survey. Next, results don't necessarily generalize to all physicians in Colorado, and certainly to physicians in other states or other countries. Of note, this was also done in the midst of the COVID-19 pandemic, and so there may be limitations on our ability to generalize the results to other points in time. COVID had a way of bringing up sort of death, dying, and end-of-life preferences in patients and physicians in ways that may not generalize to other points in time. Finally, the findings are limited to the topic of MAiD because that's what we surveyed about, and they can't be generalized to other medical services in which conscience-based barriers or conscientious objection may be prevalent. So to begin summing this up, approximately a quarter of physicians in our sample had personal religious or ethical barriers to their own participation in MAiD. Of physicians with conscience-based barriers to MAiD, 2/3 reported both religious and ethical barriers, suggesting that for these physicians, their religious and professional ethics are very closely aligned. Physicians who reported religious and ethical barriers were often willing to participate in some activities in the multi-step process towards MAiD. There has been commentary over time or concerns that physicians who hold these beliefs may feel complicit in the act of MAiD if they're to participate in any portion of it. But this data really points to the idea that for these physicians with barriers, what it means to participate looks different for different people. We also found that the vast majority of physicians with religious or ethical barriers to MAiD acted pretty consistently with their beliefs, especially when it came to the much more active components of the MAiD process, such as consulting or attending. So just to touch briefly on some of the policy implications, we identified that there was really a unique category of conscience-based barriers that were distinct from practical barriers to participation in MAiD. Things like lack of knowledge, the time or emotional investment, or the employer practices or employer practice policies and procedures. We use the language of barriers, but they're not necessarily barriers in the sense that we want to overcome someone's religious or ethical objections to participation in MAiD. Secondly, I would emphasize the importance of having policies that support this relatively large minority of physicians who conscientiously object to providing MAiD services, while also being mindful to protect patient rights and access to a service that they are legally entitled to, at least in the state of Colorado and elsewhere. Third, because there is this small minority of physicians who participate in MAiD services despite holding conscience-based barriers, institutions may consider ways to formalize MAiD referral pathways or physician well-being resources to support the physicians who participate in MAiD despite holding these barriers. And then just to wrap up here, so where do we go from here? From a research standpoint in particular. We see that MAiD comes up on the legislative agenda in many states, year over year. I feel confident that this is going to be continue to be present in the social and legislative landscape. Death and dying and end-of-life considerations are one of the only certainties in life, as sort of cheekily illustrated by this figure from The Onion, satirical newspaper publication many years ago. And so importantly, we might think about or consider looking into the ways in which physician barriers to MAiD intersect with patient-clinician relationships, trust, and patient and family experiences with end-of-life care. I think there's also a need for larger studies with more diverse samples to better understand some of the nuance that comes with this really contentious but prevalent topic. For folks who are interested in more details of the work that I presented today, our work has recently been published in the Journal of General Internal Medicine, so that's now available online. But for now, I'd just like to say thank you so much for your time and attention, and I look forward to hearing Dr. Caplan's remarks and engaging in conversation with you all. Thanks so much.
Thank you, Dr. Hamer. We're now going to turn it over to our respondent, Dr. Arthur Caplan.
Well, thank you. And thank you very much, Mika, for that report in that study. I have to say there is no data like it anywhere that I've seen. So bravo for undertaking to examine this very important aspect of end-of-life care and management. I also want to say, which ethicists rarely do, that I think you did a very nice job being ethically sensitive in how you recruited the participants. That's a tricky area. Not everybody wants to be known, as you said, and the state is making extraordinary efforts to keep, if you will, the practice private. And so, it's tough. Everybody should be aware who's on the lecture in the Zoom that this was done, I think, in a very sensitive way. I don't know what the IRB had to say to you at different points. Maybe you could tell us if there were concerns about undertaking this work on a sensitive subject. But from what you said, it looked to me like it was done very carefully, even though you're working your way back to identify people. The path back seems to me have been handled very, very well. So just as a general comment, I wasn't surprised to find out that a huge number of the people who do this are involved or have cancer and neoplasms. This almost was invented for two conditions, MAiD. I think one was AIDS, the tail end of that, and the other was cancer. And it tends to be a practice that isn't particularly attuned necessarily to other diseases. So I don't know if in your questioning and qualitative surveying, whether that came up as doctors saying, I'm not comfortable with this, my patient doesn't have cancer, my patient is dying of some rare thing, could have even been COVID during COVID. And I'm not sure I'm comfortable managing what's going on, because I think it's more oriented toward people who've got the 6 months to live and are kind of slowly leaving, and we have time to establish competency and we have time to wait for reaffirmation of what they want, and our prognostic knowledge is better about what's going to happen. I don't have that with respect to some of my patients. So as a general comment, again, yes, I think cancer still dominates, and it always has, but that may lead to the need to educate doctors or talk with healthcare providers about this may be relevant for many other kinds of diseases. I think it wasn't clear generally whether people were bothered at all about the way competency assessment is done in Colorado. My understanding is that in the states that do it, they all have some version of a competency assessment, but they don't really invoke it routinely. They invoke it when somebody has a concern about competency. So perhaps as part of medical ethics concerns, I don't know, some people might have said, I'm not so comfortable with the way this goes. If nobody worries that the person might not be competent, then we don't get a competency assessment, even though maybe that's influenced by the desire to let this happen. So as a general comment, that's certainly one area where I'd be interested in knowing the basis for worries on ethics grounds about getting involved with the practice. More specifically to your data, I'm certainly interested to see how rare this is. It's just rare. People don't understand that most people don't do this. So that raises a number of important questions that your data gets at. While you found people who could have had MAiD-eligible people and then looked to see what their participation was and what they did, you know, the broader question is who's got people out there that didn't even get to the way in which you sought out people who might have been involved with MAiD and had conscientious concerns about it. The number seems to me extraordinarily low participation rate. Now, whether that is because at the end of the day, most people don't want to shorten their lives and will do anything they can to stay on, or whether people just don't know about the option, I don't know. I'd love to find out. The number makes me wonder. So that's a concern. Secondly, you didn't report, and maybe you couldn't ask, but why people changed their minds. Did some of the doctors have reservations that they conveyed to patients? And then as a result of an interchange, somebody said, I think I'm going to do this, decided not to do it. And that could be either, I don't like the fact that you're doing this in an early discussion. It doesn't square up with what I think a good death is. Or could it be because other people intervene, family members, whatever? I'm not sure, but that, you know, people who say, give me the meds and don't take them is not an insignificant number either. So it's an interesting question. We know why doctors might say, I'm not going to do it. But what is it at the end of the day that leads many patients, if you will, to have a change of heart? I'm not going to call it conscientious objection, but change of mind about what they're going to do. I think you showed the referral rates in Colorado, and they weren't that different between those who said they would do it and those who said they wouldn't, but they're bad. A 45% rate is not very good about referral. So as a critical comment, I know this may come as a horrible comment upon empirical data where people don't like to jump to the normative, but I'm going to say that stinks. Everybody should have a referral. Everybody should then decide what they want to do. If you're dealing with someone who doesn't want to participate and explains that to you, or an institution that doesn't want to participate and explains that to you, the overriding ethical requirement for consent and information about options, which is a part of a true informed consent in managing one's dying, I think demands some policy response to make sure that the option is known. And remember, the number of people involved as reported seems low. And then this referral rate number I find disturbing in terms of what I would really hope would be closer to 95%, both from those who say they can do it and those who say they don't want to do it, because overarching, the individual physicians thinking about conscientious objection should be the patient's best interest, the relationship of trust that I will give you all the legal options in Colorado that you could use. And that is a policy implication, I think, that has to be bridged. And I'll add to that. I'm a little disappointed that some of the people who opposed it or didn't want to do it still were not present when it happened. One could argue that that's a version of abandonment, a big ethical no-no within doctor-patient relationships. Even if you don't like it, why would you not be there at the death of your patient? I mean, some can't go because they're busy, or some can't go because this is going to take place in a different geographic part of the state than they're in. I get all that. But witnessing, holding one's hand, being there to support, even if you don't like what the patient's doing, I think is an ethical issue that needs to be closely examined as a matter of policy and training. I really don't like to see that number down at around 0 or tiny percentage points when someone actually goes through this, if the doctor could be there, and especially if there's been a long relationship with that doctor prior. I would hope that that rate could come up. There's no reason. I mean, if doctors didn't show up with every patient they disagree with their lifestyle, there'd be a lot of unaccompanied patients in a lot of healthcare institutions. So this area, again, I think conscience is one thing, but support, witnessing, not abandonment, psychosocial support for the patient, whatever their manner of going might be, I think is very important as coming out of this data is something to look at. It makes me even think that, I don't know what's going on in Colorado, but you could find it out. CME training, what's going on in continuing education, what are doctors told? Some are saying they have professional ethics refusal, more than religious. And by the way, Colorado's in the bottom 10 states of religiosity, so you wouldn't expect it to hit there as much as it might in a state like Alabama, which happens to be at the top of all states in terms of citizens who say they're extremely religious. So a lot of this is done on professional ethics grounds, at least so stated. So are we training people properly? Is that something that either people who are doing it need to think harder about in the other direction, or vice versa? How has that area evolved? And I would say also among others who are involved in palliative care, hospice, preparing advanced directive training, that includes lawyers, it might include social workers. What are they being told about what ethical expectations are in terms of the morality of doing this, not doing this, what their professional association says? In New York, where I am, the professional society moved from opposition to neutrality. I'm not sure the education caught up with that. So things change and evolve. And how are they doing, or what are they saying, or what is the messaging that one might get on this, I think is an area that needs to be examined. Last comment, I do think people worry a lot about slippery slopes. We just saw in New York State the 5th defeat of legalization of Colorado style MAiD, exactly the same sort of format over a period of, I don't know, 10 years. The main argument, I believe, that saw the state decide not to legalize, they didn't take a vote on it, it died in committee again, is that they worried about a slippery slope. And you presented a little bit a kind of concern that opponents have about slippery slope using the existing narrow eligibility law. I can't find any evidence anywhere that that slope has ever been traveled. I don't know if those who have professional ethics concerns believe that somewhere there's abuse, but again, limited data. But if you look at both state reports, Oregon, if you look at media reports, you just don't see much in the way of somebody got bullied into this or rushed into this, or the disabled are overrepresented, or the poor aren't there. In fact, as you probably know, the poor are underrepresented more than overrepresented in people who select this. So it'd be interesting to know, is that a slope that worries them professionally? Or is it the emerging slope, which is Canada and Europe, where MAiD is being expanded to people with mental health suffering, moving from a standard of terminal illness, which is the American 10-state DC narrow Colorado version, where people basically believe they're not causing a death. They're assisting a style of death because it's for the terminally ill, to Canada and Europe, Belgium, Holland, where you see legalization based upon patient suffering, which is a much broader group that includes depression, anorexia, people maybe even post a terrible loss, grief. Could be, I've had it with my disability. They're not dying. In New York, I think that argument is one reason we didn't pass legislation yet again. It's that slope. It's not the narrow slope with the protections that Colorado has. It's this issue that has emerged of expansion and more eligibility. So I don't know whether that's driving worries on the part of healthcare professionals, doctors in Colorado. It definitely is in the national debate. But I'll suggest, by way of a final comment, there are two slopes. Abuse of the narrow terminally ill standard, which I don't see. Abuse of the suffering standard as an expanded criteria, which many people have deep ethical concerns about, in terms of then saying, well, we are causing the death of someone. If we do this, it's not helping someone die in the manner they wish. It's assisted suicide flat out. And I'm against that, and my professional code won't support that. And if that's where we're going, if we legalize this, or if that's where we're going, if I participate in this in the Colorado sense, then I'm not sure I can get involved. So again, thanks for the snapshot. Very useful to have it. I think it's got a lot of important policy implications.
Thank you so much. Gianna, I don't know if you want to do questions from the chat or if you want me to respond to Dr. Caplan's response at all.
Yeah, why don't you respond? And then we do have quite a few questions.
Okay, great. Well, I won't cover everything that you mentioned, Art, just because you covered a lot of ground. But I guess just a couple of reflections on some of the things that you brought up to sort of start working backwards, the slippery slope aspect. I really see this as one of the issues of the lack of data and empirical data in this space, because I think you can convincingly make an argument that there may or may not be a slippery slope. And people can easily wrap their heads around where that might come from, whether or not there's actual evidence to demonstrate that that's happening. So, while other countries serve as useful examples, or they still have, it's a very different environment, right? Even the healthcare landscape is vastly different here than it is in Canada, for instance. And so I think some of the concerns that may be prevalent elsewhere may or may not sort of come to fruition here if things were to be expanded. So it's definitely something I'm keeping my eye on. I'm really interested in it. But it continues to kind of astound me in some ways, but also not surprise me in others, that, this lack of data really serves as the basis for not moving legislation forward, which I think is really interesting. In terms of some of the things that you raised around people who fill the MAiD prescription but never take it, I think that piece of patients and families who are engaging in the MAiD process is, again, a really understudied area, and one that's particularly interesting. One of my hunches, which is not really based on empirical data, but I suspect that for some patients, just accessing the MAiD drugs and having them in the cabinet is sufficient to sort of allay their existential crises or feelings of being out of options. When they have the drugs on hand, they're not actually out of options. Many of these people are very close to the end of the life regardless, and some end up dying a natural death prior to actually engaging in the MAiD process fully to the end. But understanding kind of the implications of that and the decision-making process, even when patients decide to take, how do they pick a date that's the date for them, is an area of real strong interest of mine, but one that, this is really just the tip of the iceberg. So I'll stop there just because I want to make sure we have time for questions from the audience, but thank you again. Really appreciate your feedback.
Great, thank you. And these questions are for both of you. We got quite a few, so I'll try and hit the more popular ones. There were a couple questions about speaking to MAiD in the case of advanced neuromotor disease, or ALS, for example, when patients lack the physical ability to self-administer.
Yeah, I'll speak on a limited basis to this. I'm not a physician or a clinician, so my knowledge of this is strictly on the research side of things. But that is an area that receives a relatively large amount of attention, and my understanding is it was in part one of the reasons that Colorado moved to shorten the waiting period between the two requests. For some folks with ALS, their motor capacity deteriorates quite rapidly towards the end of life, and their ability to self-administer the medication diminishes or is eliminated entirely, which may mean that, even if they want to engage in MAiD, they are no longer able. So my sense is folks are trying to work within the confines of, the eligibility criteria as they are currently laid out, but to make sure that patients can have their preferences, needs, and desires met.
Great, thank you. We also received quite a few questions about physicians being present for the administration of MAiD, if there is a requirement for that in Colorado, and if not, should there be a requirement?
That's a great question. I don't believe that it is required. People can self-administer at home. And in fact, many hospitals and health systems forbid MAiD completion within their facilities, even if they don't prohibit their employees or their physicians from participating. So it's not a requirement. Whether or not it should be is an interesting question. The aid in dying drugs work pretty well. I am not aware of any instances where it hasn't gone as planned, and suddenly someone finds themselves in a really critical situation where they would require medical care. So, that would be the reason that I would think you would want a physician present. But to speak to Art's point earlier about non-abandonment, preservation of that patient-clinician relationship, I think it can be a really important part of the dying process, not only for the patient, but also for families to have that support and, reassurance that the things that their loved one is going through are normal and part of the process. Dying doesn't occur the way we see it in movies. Like, it's not just an instant thing. This can take, hours to days even. So I think it's an open question. Art, you're muted, but we'd love to hear from you.
There you go. I'd just say two quick things, watching time. One, I wouldn't require it, but I would discuss with doctors their obligation, their duty to be present if the patient requests it at their death, if they can do it. I mean, again, it's all, where is it? And can I get there in my schedule? But have the discussion. I mean, I think staying with patients wherever they're dying, whether it's this way or just dying, if you have a longstanding relationship with a patient, part of it may be to honor the commitment to try and attend. Maybe it could extend even to a discussion of the funeral. It's sort of making death and dying as comforting to the survivors, as comforting to the patient as possible. But I just wouldn't require any old physician to be around. That's not achieving what I'm looking for. But that said, I think whoever's doing this and the family better know what to do if it doesn't work. So that could be a part of the planning. We call 911. They can't come into the institution because it's not supposed to be happening here, or, whatever. I think presenting the possibility of longer time, it didn't work, and how to manage it, that should be part of what MAiD requirements are.
Thank you. I think we have time for one more question. And this is specifically about some of the language from your survey. Is it a bit disingenuous to suggest that the choice of barriers does not imply an obstacle to overcome, as opposed to reasons for declining to participate?
That's interesting. I think, because the question appeared in a battery style survey question of things that may or may be barriers or things that got in the way. Choice of language is in some part due to space limitations on paper surveys and needing to fit it onto, one page front and back or a couple of pages front and back. I I think you can see it both ways. I can certainly appreciate that one might see the word barrier and think, gosh, you're really coming in with an agenda to like change people's minds on these things. But certainly, for concision and asking the questions, and in framing it in terms of really just what are the things that prevent or get in the way of you participating in this. A more concise way to say that is simply the barrier. So I can appreciate where the comment comes from. Anyway, something that we'll definitely be thoughtful about as we continue to move ahead with this line of research in the future.
Wonderful. Dr. Hamer, Dr. Caplan, thank you so much. This was a wonderful discussion. For our viewers, this will be available at the Center for Bioethics website, which was shared in the chat, as well as the publication that Dr. Hamer shared. Thank you, and we look forward to seeing you at our grand rounds in the fall.
Thank you.